So during this presentation, I will not have access to messages. Okay. So this topic, as I said before, is a wonderful topic. Falls in the elderly, an ENT problem, geriatric problems, or nobody's problem. We will answer this question at the end. Okay, but we will answer this question at the very end. But then we will go through a process before we answer a question. So there are three framings, okay, which we can start from an ENT perspective, from a geriatrics perspective, and from the nobody's problems perspective. From an ENT perspective, when the person comes, like what we do as an ENT, our responsibility is to rule out an ENT condition. So it's the first thing that we see is if person comes to us, it's vertigo. That's it for us. It just means vertigo. The very fact that the person presented to us, it tells that we just conclude that it is vertigo. It could be BP, PV, whatever, vestibular neuritis, mini areas disease, the usual list that we go through. The moment the same patient with the same fall just presents, instead of coming to the ENT OPD, goes to the geriatrics OPD, the same particular person is seen in a totally different light. They'll start thinking in terms of polypharmacy. Maybe there are too many tablets that the patient is taking. Generally, there is some amount of frailty related to aging. Okay, then they do multi-domain risk assessment. And one important thing that the geriatrician pays attention to is a continence related fall fracture matrix. What is that? Continence. They have uh, urgency when it comes to urination and these things. So they need to rush to the bathroom. And this is the time when they suddenly fall. Most of these geriatric people, this is a very, very common condition. The rush to the washroom is what makes them fall. And the rush is also seen as part of geriatric condition. Then when it comes to the other framing, that is the nobody's problem framing, she fell, she's old. That's it. At that age, what do you expect? Okay, this is another framing. So it can be the three questions that you gave me. When you look at it, it can be seen in three different ways. Does any of these things provide a solution? Okay, let's just look at this patient. This is not at all a hypothetical patient. This is the kind of patient we've come across seen. There's an exact patient like this was presented in DizzyCon in Kochi by a geriatrician. 3 falls in the last 6 months. ENT, Dixalpic is done, not vestibular. Cardiology, Holter is done, it's not cardiac syncope, so it's not a cardiology problem. Goes to the orthopedician for knee osteoarthritis. Okay, see some knee osteoarthritis, does some conservative management of the osteoarthritis. Goes to a general practitioner. General practitioner gives multivitamins, walking stick, but general practitioner does check the blood pressure also, but an orthostatic blood pressure is never done. 6 months later, fall on the way to the bathroom at 2 a.m., fractures the hip. Now, whose problem was this? Who owned the falls problem? Okay, each specialist just took care of his slice of the problem, but nobody answered the patient's problem. Nobody stopped the patient from having the actual fall. Okay, nobody stopped that. So this situation is not at all hypothetical. This is a very common situation. We keep coming across this thing. We are in a symptom-based specialty. We are not in a organ system-based specialty. An organ system-based specialty like a hepatology, gastroenterology, that would be like an organ system-based specialty, okay, would just mean the problems there. And we are unfortunately becoming organ system-based specialties, even in this fall field. Therefore, if patient comes to an ENT, we are only looking at ENT rather than looking at what caused the fall. Okay, so this is the problem. There was one particular patient which I remember very, very well, okay, with Dr. Balamurugan, and that was a fall of a cardiac cause of a cardiologist's father, and which was recognized by Dr. Balamurugan because he looked at the patient holistically rather than looking at his slice of the problem. So this is a very common situation. Now, this is not a rare event. 1 in 3 adults fall greater than above 65 years age of fall every year. Above 80, 1 in every other adult has a fall. 95% of hip fractures always begin with a fall. And injury death in older adults, this is the fall is the most important cause. Ask any elderly person after a certain age, what is their biggest fear? The biggest fear of an elderly person is not death. Everybody knows that with birth comes death. Maybe there is a certain amount of time up to which we are scared of death. But after a certain amount of time, it is not the fear of death. It is the fear of being dependent, that you will become bedbound and then you will be dependent. You will be a burden on people. That is the biggest fear. And that fear is compounded or increased by one single fall. And that fear is what with which a lot of elderly people live. It's really just an event. It's an opening of a cycle. Once the person falls, hospital administration happens. A lot of deconditioning happens, fear of falling. One fall, fear of further falling. Social withdrawal because of all the fear that they develop, their fear of becoming dependent on all of these things. And because of social withdrawal, then there is reduced activity. Reduced activity, this person had a sarcopenia and then had a fall. Now reduced activity worsens the sarcopenia. What worsens the sarcopenia? All these things lead to the next fall. One fall will start a downward spiral of propagating and feeding the next fall. The first fall is just a warning shot. The intervention window opens and closes very quickly, and we have to optimize on that particular thing. Okay, why falls fall through so many cracks? Okay, ENT, we just look at BPP, vestibular neuritis. Meniere's disease, cardiology looks at this. I mentioned before, arrhythmia, aortic stenosis, reflex syncope. Neurology looks at stroke, whether it's a Parkinson's, whether it is seizure disorder. An orthopedician looks at whether what is the fracture that has happened because of the fall. Whether the person has an end stage joint. Geriatrician looks at polypharmacy, frailty, condition, all these things. But the single biggest category of the falls is a multifactorial falls, okay, and they don't find a natural home in any one single specialty. Okay, they don't find a natural home. In fact, the fear that we have, in fact, what I see now in our practice here is that when we have an elderly patient with a difficulty in walking or an elderly patient with a fall who has come to us, the problem previously that we used to face a few years ago is that we never had an explanation for a fall. But now what has changed is totally different. And that thing is this. What has changed right now is that we see not one but multiple causes of falls. Okay, in the same person, there's going to be vestibular dysfunction. The same person will have a very low vestibular score. The person will have a very low tandem score. The person will also have an orthostatic drop in blood pressure. The person will also have a BPPV. So and then the person will also be on polypharmacy. So multiple factors is the single biggest category of the reasons why the person will be falling, and we need to address each of the factor to help some people. You get a pure orthostatic hypotension patient, it's great, okay, but then there are people who have so many other things. So start with one question: was there a lot of loss of consciousness? This is there for falls throughout. From the young to the geriatric, this question becomes very important. The LOC branch and the non-LOC branch. The LOC branch is where the syncope, cardiac causes, the seizure causes. Okay, seizure has a bimodal present peak. So there is bimodal in age. That means in the young people, there is a high chance of a new onset epilepsy. Then in the very elderly, again, a new onset epilepsy. So there is a bimodal distribution of seizure. We need to recognize that it is not like an elderly person cannot develop a seizure disorder for the first time. It can happen. That is the bimodal distribution that I'm talking about. Then, of course, there is the tumarkins and all of vertebrobasilar, not the tumarkin. Tumarkins should not be coming on this side. It's not on the LOC branch. It should be on the other side. Okay, I'm sorry for that error. Okay, so when it comes to sustained imbalance, okay, which leads to, that is like there are falls because of gait disorder. Okay, there are multiple different types of gait disorders which lead to falls. So a simple branching and a screening for gait disorders will help a lot of these patients. In my center, what we do is we give a very, very high importance to orthostatic hypotension check, very high importance to ruling out bilateral vestibular loss. And then we also think in terms of other conditions, BPPV. 3 screenings we always do. And of course, we can always look for muscle strength and these things. Simple things to remember. And that is the theme that I'm going to build on in the next few slides. Think 4 big causes, three big causes, four additional causes, and it should take care of a lot of your patient's problems. Okay, so that I will come to that. So if walking itself is the symptom, okay, if walking difficulty is the symptom, read the gait. And these are the phenotype that all of us have been taught from our undergraduate days. Okay, that there is a sensory ataxic, that is stamping type of gait. Okay, which is because of a dorsal column effect or a large fiber neuropathy. Large fiber neuropathy is so simple to pick up. 128 hertz tuning for pet kept on the foot is all that is needed to make a diagnosis of this. Okay, cautious en bloc and freezing type of gait is normal pressure hydrocephalus. Okay, festinating, shuffling gait, basal ganglia lesions. These are Parkinson's disease, multiple system atrophy. Okay, then when it comes to wide-based and lurching ataxic gait, cerebellum is there. Of course, there are types of spinocerebellar ataxia, paraneoplastic canvas. Lurching with only imbalance, bilateral vestibulopathy is there. Spastic or scissoring gait uh, is seen in cervical spondylotic myelopathy. Okay, there is a lot of spasticity. Steppage or a foot drop, there is a peripheral nerve palsy and these kind of things. Antalgic is as if the person is having a pain in the joint, the way the person walks that way. That is a osteoarthritis feature. Waddling or Trendelenburg is quite common. That is where the person has a muscle weakness because of which they walk like a duck. Okay, bizarre and inconsistent is functional, and never underestimate functional in the elderly people. Why functional in the elderly people? A lot of elderly people are in the present day going through what is called as a empty nest syndrome. And that empty nest syndrome is really devastating. What is empty nest syndrome? Is that when the when the bird lays eggs and then the lays eggs hatch and the eggs hatch, and after that the birds come out, they feed, and then after some time the small baby birds, they become a little big and they become independent, and they just fly off the nest to make their own nests, and they make this thing. At this point of time is the parent birds, the mother and father birds, they go through a severe depression or that which, so they go through that traumatic period is called emptiness. And today we see innumerable elderly people going through empty nest syndrome, because they are there, they are alone, they are here. There is a kid in Germany, there is a kid in Australia, there is another kid in US, whatever, there is nobody at home. Okay, and they are alone, they are lonely. Okay, they are doing, house after house is being built. Okay, but then there is nobody, there is nobody to be there, and this leads to functional problems. I have personally seen functional problems, okay, in elderly people. Okay, so this is one more thing that we need to keep in mind, and that gives a low mood, that makes them immobilized, and that leads to the process of sarcopenia worsening, all of these things, and then that can also contribute to one of the contributors to fall. Okay, so but then most important thing, the three under-recognized, and then one extra thing, that is what I'm going to stress today on. That is orthostatic hypotension, sarcopenia, and osteoarthritis. Keep these three things in mind whenever an elderly comes to you. Okay, missed because they are okay, not because they are rare, not this, because we don't look at them. This is the most important thing. Just remember these three things. If I want anybody today who has taken the pain of attending this today, or who has given me the privilege of your presence here, if I have to tell you only one thing, that is this: remember these three things: orthostatic hypotension, sarcopenia, and osteoarthritis. Orthostatic hypotension, my friend Nilothpal shared a patient who was clear orthostatic hypotension, who was being treated at a very famous vestibular specialist's place for triple PD. Just imagine orthostatic hypotension being treated as triple PD, just because it was not suspected, just because it was not looked for. This is what is the missed, not because they are rare, because we do not look. Okay. So orthostatic hypotension, the definition first. There are some things to be named, and I'll share a tip about orthostatic hypotension here. We see that this thing, 22 millimeters of mercury systolic drop or 10 millimeters diastolic drop is considered as orthostatic hypotension. But this is the textbook definition of orthostatic hypotension. Clinical definition in active standing. See, active standing kind of testing is in our clinic, when we practice, we do orthostatic hypotension. We don't do what is called as a head-up tilt test. We do what is called as active standing test. What the difference between a head-up tilt test and an active standing test is, in a head-up tilt test, you put the patient in a couch, and the couch tilts up. The person does not put any muscular effort to come upright. So this particular person it's very sensitive. So the orthostatic drop is really manifest very well. Whereas in an active standing test, like what we can use in the clinic every day, where the patient, after being supine for 5 to 10 minutes, is asked to stand up. Active standing involves some amount of abdominal muscular activation, some amount of limb muscular activation, and therefore this amount of drop in blood pressure cannot be demonstrated. So even in a clinical criteria, in the active standing criteria, even a 10 millimeters drop is still significant if the patient's symptoms are suggestive of orthostatic hypotension. One important thing to remember is a variant called initial orthostatic hypotension. This is so important because this is the principal reason for orthostatic hypotension related falls. The moment they get up in the morning, patak, they have fallen. Okay, the moment this thing. And this is missed in routine practice because we wait for some time to do. The actual recommendation is that it is not a cuff blood pressure, which it needs some kind of a continuous blood pressure. Okay, continuous blood pressure sometimes can be invasive, so it's not practicable all the time. So there is a little bit of solution, not exactly the less than 15 seconds, but if it's happening at least less than 30-40 seconds, you can pick this up. And that one is this: inflate the cuff even before the patient stands up. Inflate the cuff when the person is still supine. When the cuff is going up, 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 that is the time you ask the person to stand up. What happens is, now when the cuff is getting deflated, okay, now the inflation time is not wasted. So you have, if the BP apparatus inflation time is not wasted, direct during deflation, you check the blood pressure. So you will not miss so frequently the initial orthostatic hypotension. There was one patient which examinations, this initial orthostatic hypotension. He used to come with falls again and again. Okay. And then I used to think he is BPPV. BPPV was never coming. Then it turns out then the classic orthostatic hypotension, which can be picked in any clinic if you care to just check the supine and standing blood pressure, is the 1 to 3 minutes drop. This is called the textbook form of orthostatic hypotension. And we have the delayed orthostatic hypotension, which needs the person to be maintained standing. That is why in our clinic we wait for 10 minutes minimum. Okay, 10 minutes minimum. There is another way of delayed orthostatic hypotension, which is really delayed over 1 hour, 2 hours, and all of those things. For that, what we do is, when the patient comes into the OPD, first, even before we make the patient by an initial sitting blood pressure, we do check. So there, if it was low and then supine becomes high, that tells that this person was having a very delayed orthostatic hypotension. Okay, so I think that concept is clear to everybody. That's orthostatic hypotension. The workup and treatment is this. Okay, the usual workup, simplest minimum, is a 3-minute active stand at every visit. Check, make sure that it is done. Then, of course, when the delayed is suspected, or then you can do a proper head-up tilt test. Look for whatever you do. See, orthostatic hypotension, there are causes that are not much in our hands. The autonomic causes, that is as associated with Parkinson's disease, associated with multiple system atrophy. Just yesterday, we had a patient with multiple system atrophy or Parkinson's disease. It looks like multiple system atrophy for me, who had orthostatic hypotension. Okay, so these cases, there is not much to really reverse about. We just have to manage. Whereas just one line up is the reversible causes. In the reversible causes, when you see drugs, dehydration, anemia, adrenal insufficiency, all of these things, of course, amyloid. Okay, cardiac coexistence, okay, is another thing which can be a contributor. So when it comes to treatment, the first attempt should be to de-prescribe. Okay, just de-prescribe. I had one particular patient, okay, it was referred by my friend from hospital. He has a very high regard for me. He knows that you send the patient to him, he will somehow find an answer or something like that. He used to send, but there was one particular patient, 6 months, 7 months, 1 year, I could not find an answer. I was just struggling. What is happening? One more day, I started a history again. And on that day, I got. And then he tells, sir, when I don't take these tablets, those days I feel better. Okay, those days I feel better. And that's it. That was the clue. Then we figured out, and then we changed the medicines, and then he's doing great. Okay. So then all the time imbalance in walking, dizzy, this kind of thing. And these are the things which will end up requiring, end up in a fall. Okay, so de-prescription of the drugs is most important. All of us somehow feel a compulsion to add a medicine. Very few of us feel a compulsion to remove a medicine. I will promise you, if from tomorrow you start looking at everybody's prescriptions, you will at least find a multivitamin which has been in a lot of patients, which has been doubly prescribed. Okay, a multivitamin. This guy also would have given a multivitamin. Another guy also, and the patient will simply be taking two multivitamins. Somebody will be taking two beta blockers. Okay, one will be taking. Okay, so these things are happening. So when we look at that, we can always de-prescribe some drugs. There will always be an opportunity to de-prescribe drugs, and that will be a one of the big solutions to this orthostatic hypotension. Non-pharmacological management salt. There is one wrong behavior or one wrong belief in people that we should not eat salt. Our body, okay, salt gives taste to life. And people tell don't take more salt. Okay, for whatever reason, people have been telling, and this has been so counterproductive in the elderly population to tell don't take salt. Okay, and then they go into hyponatremia and all of them. No, they should start taking their normal quantity of salt. Okay, I have a patient who's been an IAS officer. I saw him on a consultation. He was on two diuretics which waste salt. In addition to two diuretics which waste salt, he was also taking low salt diet. And he was devastated, not able to walk, not able to go out, all these things. Saw the two diuretics names and this thing, just stopped the diuretics, asked him to start taking his normal salt content, and everything is perfect. Okay, so this is what happens. Just imagine it can happen to an IAS, retired IAS officer. If it can happen to an IAS officer, these kind of things, it can happen to anybody. Okay, so we need to look at the drugs, we need to look at what is happening to the salt intake and all of these things, and then do this. Of course, thigh compression, sleep at head up 10 degrees to the sleeping with the head little high, about 10 degrees, prevents what is called a supine hypertension. When the supine hypertension is prevented, the diuresis that happens at night, because to handle the supine hypertension, diuresis is where they go on passing urine, pass on secreting urine at night. Okay, will next day morning will cause a um, drop in blood pressure, and that is going to cause. So pharmacology, midodrine is one option. Okay, fludrocortisone is another option. Okay, and then there are, of course, there are the droxidopa and other medications that we can consider. Okay, please always supine hypertension coexist. This is a very, very important point. I'll stress that in the next slide. This one term called supine hypertension, please remember this. This is a very, very important term to remember in the workup of orthostatic hypotension. What exactly is supine hypertension? This is a supine hypertension paradox. What happens is, why this orthostatic hypotension is not captured or caught in a OPD? Is it that the physician or the general practitioner who saw the patient did not care to even check the blood pressure? No, they did care the blood pressure. They did check the blood pressure. Neurogenic orthostatic hypotension frequently coexists with supine systolic blood pressure greater than 150. Okay. So now what happens is, the person comes, I have one patient from Mysore just 1 month ago. He went to the doctor and told, what is this doctor? He's again and again telling that your blood pressure is going low. Your blood pressure is high. Why? When the person goes, they make them lie down on the couch, and on the couch, they check the blood pressure, and blood pressure is high. This is supine hypertension. And when it is supine hypertension, they tell, how can you be hypotension? You need to know the concept. This is a trap. Supine hypertension can be associated with orthostatic hypotension. And if you know this, then you will not stop at just checking the blood pressure in the lying down position that we usually do. Now you'll start checking the blood pressure in the standing up posture also. Of course, all these things, this is the drug cascade that we need to look at. Today, I was just having a review with my clinical team. Okay, I have a beautiful clinical team of highly motivated people. Okay. So what one thing we can improve, what we can do better? One thing that we can do better is to make sure that we make a complete list of the drugs that the person is on, and then run through those mechanism of action, what it can be producing. So these things we should be looking for and checking which of them could be worsening the problem. So TRAP3 is postprandial hypotension. It's a separate phenomenon, completely separate phenomenon. This is like this. This person in between meals, if you check the blood pressure, orthostatic, you may not get anything. It may not at all be sensitive. So sometimes it is like about an hour, okay, 15 minutes to 190 minutes, but somewhere around about an hour after their heavy meal, if you check, you will start picking up these cases. So just ruling out in one visit or one case when the history suggestive of orthostatic hypotension may not be adequate. In that case, you may just have to ask the patient to have lunch and then come back and then test, and then we'll get it positive. Okay. So this is the orthostatic hypotension. I wanted to stress three conditions and a fourth condition. So the first condition I've already stressed, that is orthostatic hypotension. I think the message is clear. Look for it, check for it, okay, and use the trick of cuff inflation even before the patient stands up, so that you don't miss the early orthostatic hypotension or the initial orthostatic hypotension. Okay. Then sarcopenia is the next big thing. It's not at all suspected. Okay, it's not at all suspected. Low strength, low muscle quality, low physical performance. What happens is, and there are some people who may look hefty, but the quality of the muscles is gone. The amount of skeletal muscle in their muscles is less, amount of fat in the interstitium of their muscles has increased. Okay, so this is what happens. Okay, it is not like the person is only lean. Even a person who looks fat can be having sarcopenia. This is the key message in sarcopenia that I want to tell you. Just because the person looks hefty, it doesn't matter. Okay, it doesn't mean that the person's muscles are of a good quality. So you need to look at the strength, hand grip strength, and then they take through the steps and then check all of these things. Okay, and then check the performance of the person. 40 plus, if you don't do exercise, you lose muscle. Okay, it is inevitable. Some people lose fast, some people lose slow, but the loss of muscle is inevitable. There is up to 40 where the anabolic steroids in the body are all high, they are all raging. Okay, and then they make you build muscles, they make you take wrong decisions. All of those things are different, but then that is the age up to which all these things are there, anabolic steroids. But 40 plus, they start going down, and that is the time when we need to actually start pushing the exercise regimen, which increases the anabolic steroids also in the body and also increases the muscle. So we need to encourage everybody. If there is one indication for posturography, it is to warn people that their monopedal stance has become weakened and start taking action. Okay, if that is going to be a big advantage of posturography assessment, to tell people that you are going low, please start taking action. Okay. So what to actually do at the bedside? Because you can check the strength. Can you lift, carry a 10-pound weight or whatever? Okay. Then how difficult it is to walking across the room. Can you rise from a chair without holding? Okay. In the movies and all, you can see some kind of funny scenes where people are asked to get up from the floor without taking support or anything. So you should be able to get up from the chair without support, without taking the armrest support. Is the person able to get up? Okay. So can you climb? Okay. These kind of things, and how many falls you had in the past year. Then you can, if you have a proper gait lab, you can do the gait speed and all of these things. Okay. Can you do 5 times sit to stand, and how long 5 times sit to stand takes? Okay. So these are all the things which will help you in finding out. Hand grip strength is a big thing. Okay. So there are something called hand dynamometers. Hand grip dynamometers are available on Amazon. Okay. And you give the hand grip and you ask the person to press the hand with that and check the hand grip strength. This is one. This is not really a direct measure of the postural muscles. It's an indirect measure, but the sarcopenia diagnostic criteria has only set hand grip as the tool and not anything else as a tool. Okay. Sarcopenia, the falls intervention, nobody prescribes. So this is one important thing. Sarcopenia could be the cause of fall. The muscles are not. So I'll give a simple example of how sarcopenia can be a cause of fall. Okay, just imagine this. You have seen a kid. Okay, you give a kid a big school bag full and watch the person's walk. Do you see the walk style change? If they are overwhelmed with the weight, if they are given a weight beyond what they can carry, you yourself try to carry a weight bigger than what is usual, you will start staggering, you will start not walking properly, which means and sarcopenia is a condition where the muscles have become so weak that the person's own body weight has become a burden now, and they will start staggering. So this is the thing. How to improve that? Resistance training. Progressive 2 to 3 sessions per week, the only intervention with consistent reversal evidence. Okay. Supervised training always wins because you give a set of trainings. You think the patient can do it home. No, the patient cannot do it well. They will not do it rightly. So supervision always wins. You start giving protein supplements. We give amino acid supplements here. There is a capsule called Astamin 4, which is a very frequently prescribed up. Replace vitamin D. Okay, reverse any catabolic context, whatever there is there, including any elderly depression. Okay, any elderly depression. Hypogonadism in the elderly is not really recognized. We should be starting testing them for hypogonadism, and then, if required, we should be um, intervening at that also. Address polypharmacy. This is one more important thing. Statins, glucocorticoids, okay, all of these things, whatever, okay, including proton pump inhibitors. You may not think how big of an evil a proton pump inhibitor is. Okay, proton inhibitors are like, they just make sure that the patient B12 is not absorbed. Patient thinks I get gastric, I have gastritis, whatever. They keep popping pantoprazole, omeprazole, some prozole. They keep eating, they keep eating, they keep eating. And the direct result of that is the intrinsic factor is no longer there, and they will not be able to absorb their B12 in their gut. So they start developing this thing. So sarcopenia is the second thing that I wanted to bring attention to. Okay, other than the general thing. So just to reiterate where we came from, we started off from whose problem it is. Then we had a context of one particular patient, a history, orthostatic hypotension was missed. Then I told two conditions. Condition number one, orthostatic hypotension. Condition number two, sarcopenia. There's a third condition I want to bring your attention to. This is not at all recognized. This is osteoarthritis. Not just arthritis, especially knee and hip osteoarthritis. Okay, is a big, big problem. We have to again look for osteoarthritis and then start intervening for this particular arthritis. Also, specifically, we need to reduce the pain. Okay, so the analgesia ladder is there. You can start off with a topical NSAID. There are so many different types of Overon gel, that gel, this gel. So you can try, then you can start off with paracetamol, then go to increase the steroid. Okay, sometimes even intra-arterial, within the joint, okay, hyaluronic acid you can give, so that okay, there are some people who report for 6 months, 3 months, 6 months, 1 year, their joint does better after one injection. So these things can be given. Okay, strength training, especially quadriceps. I'll come to this in a little bit more detail later. The quadriceps strength training is the single most important false intervention in knee osteoarthritis. The quads are strong, knee osteoarthritis is prevented. Okay, neuromuscular electrical stimulation, walking aid, footwear, these come later. And of course, we have a joint replacement surgery when everything else doesn't seem to work. The quad prescription for the knee osteoarthritis is quadriceps sets, the exercise prescription. Okay, you have to do this isometric knee extension exercises, 5 second holding times. Then you do a seated knee extension. There is something called open chain and a closed chain. In open chain, the legs move. Okay. In closed chain, the legs are kept in one place. This is wall squat. So seated knee extensions, in the beginning, only the person's own leg weight. After that, you can add, okay, strap on some weights. Okay, strap on knee, ankle strap on weights, and you can keep doing. And then there are wall squats. Then we have step ups to functional progression and all of these things. Okay. Adjuncts that matter is give the cane in the, if it's a unilateral osteoarthritis, give the cane in the opposite hand. Okay. Make sure that foots are better designed and all of those things. Okay. And have a supervised program so that people can start doing. Okay. Follow a certain program and they have a certain pressure, all of those things so that they can improve. So these are the three things that I wanted to tell, the three important things I wanted to bring to your attention. Always remember three things. Number one is orthostatic hypotension. Number two is sarcopenia. Okay, and third one is knee osteoarthritis or hip osteoarthritis, for that matter. These are very, very common. We are not looking for them. Start looking for them, and you start seeing the change. And these are intervention, possible to intervene and possible to do, except in the neurogenic orthostatic hypotension associated with multiple system atrophy. Most other cases of orthostatic hypotension, we have something that we can do. Even there also, maybe we can try something, but most other cases we can do something. Whatever the complaint sounds like, whatever the imaging says, whatever the patient tells, any elderly patient, you have to screen for BPPV. Not just elderly faller, forget about the faller. Any elderly person comes with any balance complaint, just screen for BPPV. You will be, can you, Pratik, you don't mind muting the mic? Okay, mics of
Yes.
everybody. Only I am allowed to.
Yes, sir.
Okay.
I'm doing, sir.
Okay. Screen every elderly. Hope I am not muted.
No, sir. No, sir.
Okay. Thank you. Thank you. Okay. So for BPPV, okay, the incidence of BPPV is very high in the elderly. Okay. Just make sure that you do the Dixalpide test, supine roll test. Try to do it with a goggle, at least a Frenzel goggle. At least a Frenzel goggle. Because without goggle, you'll end up missing a lot of this thing. And the moment you find something, okay, the moment you find something, it is so eminently treatable. Okay, so eminently treatable, and finding it treatable, because the one reason why you should be checking for BPPV is that it is treatable. And most important point that I want to tell everybody here is every BPPV patient does not come with positional vertigo. Okay, in the Mentcon oration that I gave, one of the beginning slides that I told was this: BPPV is not always positional vertigo. Okay, so it is a gravity sensitive semicircular canal, but it presents in different ways. Some people simply tell, the moment I step out of the car, I feel shaky. That's all. There are some people who tell, I just lost confidence in walking. So there are different ways in which this particular graviceptive disorder, okay, can present. So that is one more thing that I wanted to tell: screen for BPP. So in the beginning, that's what I told. The three conditions, I'm going to add a fourth condition. The three conditions you all know now by heart. Orthostatic hypotension, look for it and check for it. Suspect it, check for it. And you will see how many people. In a week, you will see at least one patient. Okay, depending on how busy your practice is. Okay, then sarcopenia, osteoarthritis, then look at BPPV, never under this thing. And then in the beginning, we told about drugs and all of these things, everything. So a simple 5-minute bedside fall screen would be: have you fallen in the past 1 year? That is a simple question. And do you feel unsteady while walking? Observe the gait. Always do, do an orthostatic blood pressure, gait observation. 5 times sit to stand. It says beautiful screen for sarcopenia and the amount of mobility the person has. It should not take more than 15 seconds to do 5 standard sits in from the seat. Okay, Dixalpine control test, please do always. And a simple cognition test like drawing a clock or 1 minute, okay, animal fluency, whatever simple test that you do. And then the person, you will be able to do. Okay, cognitive impairment is one more important risk factor. What is this cognitive impairment? How does it impact a faller? Okay, a person, just imagine these two things. Okay, this is Dr. Balamurgan's wisdom. Okay, so just imagine a person having a fall. There are two kinds of injuries with which they can come. A person can come with a Colles fracture. A person come with a hip fracture. Person come with a Colles fracture is a person who's cognitively good. His brain is good. His bones are weak. He fell, but he had enough postural responses and reflexes to outstretch his arm, and then take preventive intervention so that the body itself does not take the impact. Whereas a person who has a hip fracture means that anticipatory postural responses, that reflexive postural responses which are required to stop the big injury from happening are not there, which means a hip fracture person is also likely to be cognitively not great. So this is one more thing that tells. So cognitive screening is also important. It can tell us what kind of a fracture this person is likely to have if at all they end up having a fall. And a Colles fracture is so simple. It's just a wrist fracture. It's not, compared to, it's not that it's so simple, sorry for that word, but compared to a hip fracture, that is more straightforward to manage. This is a hip fracture which leads to bed immobilization of the bed, and then bed sores, and then worsening of sarcopenia, depression, and everything. Okay, so this is what happens. So the key principle is, whose patient is it? The patient is yours. Keep the patient. Refer only that slice to that particular doctor. Somebody has to take ownership to these patients. You have to tell you belong to me, I will take care of. But I will keep sending here, I will keep sending there for all the things. So refer that slice to that particular specialist, but you own the patient. Whether it is syncopia or arrhythmia, send to a cardiologist. Persistent focal deficits are there, neurology, BPPV, ENT, if you are not an ENT. If you are an ENT, then it belongs to you. Cognitive impairments, take the help of your geriatrician. End-stage joint, take your orthostatic hypotension. I'm sorry, take your orthopedician's help. Recurrent unexplained falls. That's it. Okay. You what? Okay. It's your patient, and then you have to handle the patient till then explanation is got. So this is how it is. Finally, why should we bother so much about fall? We should bother because false intervention produces effect sizes most drugs would envy. Okay, the interventions really help. Exercise alone reduces the fall risk by 23%. Multifactorial intervention, okay, that includes optimization of drugs, removal of unnecessary drugs, everything. 30% reduction in the fall rate. A simple home exercise program, 39% reduction in the fall risk. Tai Chi exercise is beautiful. There was one talk which was given by my brother, Dr. Surya Prakash, in Visakhapatnam long ago. We had chosen Tai Chi as a topic in the balance disorder patient. So that one is going to, of all the things, dance your way to stability. Tai Chi seems to be the best. Okay. So all of these things. But then you see that these things work. Okay. Vijay Lakshmi ma'am in Mangalore, she does a lot of this dance therapy and music therapy, and they do intervene. The opportunity here is these are not simple theoretical interventions. They have a benefit. They do have a benefit. And one fall prevented, one fracture prevented is a family saved. It's really a family saved because one person is not going to be hospitalized. So there are so many advantages to that. So whose problem is it? This is the final thing I told. I'll come to this conclusion at the end of it. ENT problem, yes, when it is a vestibular problem. Okay, there are all these causes. Geriatric problems, yes, when it is a multifactorial problem. Polypharmacy, frailty, cognition, continence problems, sarcopenia, home environment, so many things are there. It can be it can only be the topic Pratik gave. Is it ENT, it's geriatric, or is it nobody's problem? It can be nobody's problem only in a nihilistic society. And I hope that we are not living in such a bad society. Okay. That we decide in advance that at 78, fall is acceptable. No, why? How can it be acceptable? This is the same as telling that give beta-istin for everything. Why do we check? Why do they finally do beta-istinol? That is nihilism. Finally, you are going to give the same two drugs. There used to be not long ago in medicine where people would tell, finally, you do all the neurological examination and finally give that one red injection called Neurobion. Why all this intervention? Why all these tests for? There used to be nihilism in neurology at one particular point of time. It was shared by a neurology friend to me. So, but now the situation has changed. Now they see it differently. Balance disorders also went through this nihilistic phase. If somebody is still there, please, they should change. Somebody tells that in balance disorders, you do all the evaluation, it's all useless. Finally, you're going to give the same beta esteem. Then that is a nihilistic approach. In falls also, it is the same. Okay, so if you tell that, okay, it is okay to fall, then you can tell that it is okay to not have hearing after 70. So that is not the case. We can't be taking this approach. And we should own this problem. We should own our elderly. And we should make this a better society. Okay. The fall is just a warning shot. The patient survived one. The next one may be the last. You have to stop that. Now, whom does it belong to? This is the final answer. Is it belong to ENT? Does it belong to geriatrician? Does it belong to nobody? The problem belongs to the person who looks. You care, you look, the opportunity belongs to the person who cares. You are a person who cares for it. The opportunity is yours. You look for it, the problem belongs to you. And you can be that one person who can bring that change and change this. Our society is becoming older and older. The younger population is also building, that is different. But then if something drastic does not happen, most people will end up living beyond 90. And when most people will end up being living beyond 90, that fear of dependence is always going to be there. The fear of a fall will always going to be there. And the fear of being lonely will always going to be there. Small amount of spending some time with parents, encouraging people to be with parents. A little bit of addressing of emptiness syndrome, a little bit of shame to these people who think that they are earning billions or thousands and in US dollars and German currency, their parents being alone here, a little bit of shame towards them we need to introduce in this society. Okay, thank you all. Thank you so much. So what does this talk ask of you? Dixalpic, every elderly faller you have to do. Measure orthostatic blood pressure, screen for sarcopenia. Take osteoarthritis seriously as a false risk. Refer the slice. Keep the patient. Treat the first fall like a TIA. How do you treat TIA? One TIA means if you don't intervene, it becomes a stroke. If you don't intervene, it becomes a stroke. So you take TIA with all seriousness. The first fall should be taken as a TIA. Okay. So falls in the elderly is an ENT problem, geriatrics problem, and nobody's problem. It all depends on who you are. Nobody's problem, it only is in a nihilistic society. Will you be the person who cares? Thank you. Thank you all.
Sir, awesome talk, sir. Awesome talk.
Thank you, sir.
Rohiwal, sir.
Have I been muted? No. No.
You're
Am
not
I
muted.
audible?
You're heard. You're heard, sir.
Wonderful, wonderful. Very, very beautiful, elaborate talk, which has covered practically many aspects, and the most important aspect as far as our fraternity is concerned. Not only that, you have touched some social problems also.
Thank you, sir.
And this is a very beautiful talk, the most beautiful talk ever I have heard on the falls in elderly.
Thank you,
We
sir.
had listened to one talk by Sudhir Kothari in some of the webinar. Falls in elderly, before you joined, I was just telling the old people, they are they are adamant and they don't want to be seen, as they are being helped, even when they are climbing stairs or walking, and they feel that they are fit and fine. But these small factors, orthostatic hypotension, which you have touched in a very beautiful detail, that the cuff has to be inflated and then the person is to be asked to stand. It's very, very important because most of the places we see the uh, cuff which is tied around this thing, and it is automatic sort of a blood pressure. But the original older equipments, they can be used for this particular entity. When the person is standing, the cuff can be remain inflated and all. The another very important thing which you have covered is about the uh, balance problem. You can recognize just by whether the person is falling on the hand and has got a good sort of a vestibular. That
He
is
comes
a very
beautiful insight,
wonderful
sir.
thing, which
He is one of the biggest assets in our team.
yeah. He is phenomenally good. He's phenomenally good.
Yeah.
And it was a wonderful talk, and it has enlightened many aspects about the falls in elderly. I'm sure everybody who is attending this webinar will be now very keen on observing these very small things about sarcopenia, orthostatic hypertension, and everything. They are very useful in clinical practice, and it is nobody's baby is not true. Whenever a person who is coming to us for consultation, we should give full justice. There are very less questions in the chat box.
There are no questions. There are only appreciations, and I am
Only appreciation and well-deserved appreciation. It was the most wonderful talk. Dr. Vikram Khanna, I think, is raising a hand.
Yes, sir.
Can you unmute him, Pratik?
I will unmute him, but I will not be able to answer his intellectual question. Right now,
Yeah, that's very
he
true.
will only have to ask and he will only have to give the answer.
He'll ask question and he'll answer himself.
No, Srinivas, this
Yes.
was your traditional masterclass
Thank you, sir.
Lecture.
Yes, sir.
I would request that, each and every attendee of this session should be given the link of the recording, because these sessions come very far and few, and we need to revisit them to remind ourselves that we are not only treating but also caring doctors. Everybody has been touched so nicely by you that it has touched a chord in everybody's heart, as you can see from the congratulatory messages. So I think not only are you looking younger, feeling younger, but making us feel more confident and more better clinicians with a heart and not only a mind.
Thank you, sir.
So thank you for that, for making us feel as caring physicians, because ENT physicians treat vertigo, ENT surgeons don't treat vertigo, as is the general perception.
Don't go into that physician and surgeon topic, Vikram. Pratik, I think all these webinars, they are uploaded in NES website subsequently, and we'll
Yes, sir.
look
It
into
will be
that matter
uploaded
also,
in
so
any
that
YouTube channel.
everybody can have access to the webinar which you have conducted today.
Sure, sir.
Are there any questions?
I think there is a question by Nitika ma'am, medical management or protocol for orthostatic hypotension. There is a slide that I
Nikita
covered,
madam
ma'am.
wants to ask.
I'll share the slides again.
So,
Okay.
may I ask a question about how long do you give Fludricot?
Ma'am, I generally, it is not this thing. I take my neurologist help. Okay. From my own pen, fluorocortisone prescriptions are very rare. But once you start, it has to be lifelong.
And the dosage will be steadily increasing, or it will be based
That
on
I can check and I can answer you.
fine, sir.
Okay. If I am giving prescription, like if you ask me flunarizine, I'll tell everything.
Okay, thank you.
Thank you.
Pratik, you have to unmute Malik.
Sir, everyone can unmute themselves, sir.
Okay, fine. Now he's raising the hand.
Yeah, I think we can ask Dr. Malik. Kshitij sir.
Hi, how are you? Chief, I wanted to ask you, is there an objective assessment based on which you would introduce a walking stick or any other assistive a bit like a walker, or is it more subjective assessment? The follow-up would be, is there a concern if you introduce a walking stick too soon or too late? Is that something that requires pondering?
So walking stick too soon is sometimes look like hastening the process. And too late means you would have stopped, you would have not prevented a fall. A fall that a walking stick would have stopped would have been. Okay, so it means it's an all lost opportunity. So it's always better to err on the side of too soon rather than too late. But when you make a decision in favor of introducing it too soon, the walking stick, you also make sure that there is possibly a plan to get out of the walking stick also through the exercise program. That is one thing. When it comes to intervention of the walking stick, as I mentioned there, especially when one side joints are too like knee osteoarthritis is unilaterally more affecting, then walking stick really makes sense giving it in the opposite hand. Okay, sir.
One thing I'd like to add about this walking stick.
Yes, sir.
There was an unfortunate incident here at my place. The
Yeah.
senior ENT surgeon, above 80, while climbing the stairs, he slipped because the walking stick, which he was keeping a pressure on the step, it had slipped and he had a fall, and there were a lot of misery and he succumbed. He had a head injury. He directly fall on the landing.
Okay.
These people, those who are using walking stick, they are to be trained. Or now we have got those walking sticks, those who have got a claw-like thing at the end. They have to be very careful. Even with the walking stick, they feel more confident walking on slippery floors or uneven surface. So that the training has to be given a little bit by the concerned person. That's what I
Sir,
feel.
in the near future, the biggest change that is going to happen is in the clothing. So there are advanced stages of work that is going on, where you give a belt or you give some kind of a cloth.
Vestibular belt.
Not the vestibular belt. Vestibular belt definitely is there. Okay, so then in addition to that, there is a certain kind of belt or certain kind of garment which behaves like a airbag in the.
Yeah,
like a bag.
yeah.
Okay, so when the
Yeah,
person
it is,
falls and it detects the fall, it just inflates on its own.
yeah, like a car,
Yeah,
car
car
airbags
airbag.
in the car.
So now what happens is the person no longer has a hip fracture. They may fall, but they will no longer have a fracture.
Not have fractures. Yeah, that's very good has come out.
Absolutely.
Anifa, you can unmute yourself and talk.
Good evening, sir.
Yes,
Uh,
ma'am.
Sir, I'm so grateful to you, like regarding this orthostatic hypotension. After I did that course, we are keeping a eye on identifying the patients. So now, when I was preparing my abstract for the upcoming NESCON, sir, you'll be glad to know that we have 145 patients whom we have screened for autonomic function test. And out of this, sir, 4 patients came up with delayed orthostatic hypotension, and 15 patients were with like supine hypertension with OH. So, sir, now how to treat them, like supine hypertension with OH, sir?
Supine hypertension with OH, you need to handle the supine hypertension because supine hypertension is the cause of orthostatic hypertension.
Sir, like lifting the head up.
No, what you have to do is one is night. Okay, keep the
That
head
one we
elevated a little
changed,
bit.
sir. The timing.
The head elevated, number one. That is one thing.
Yes, sir.
That is number one intervention. Two, if these people, they will be taking an antihypertensive tablet.
Yes, sir.
And most of the general way in which antihypertensive is prescribed is the big dose is given in the morning and the small dose is given at night.
Yes, sir. Right, sir.
Swap it.
Okay. Nighttime it should. Yeah, we are doing that, sir.
Yeah, so you're already doing, you know everything.
No, sir. But still, sir, and this delayed
But I
OH.
know why you are asking. Has something changed between your course and now? Whether Srinivas has changed or he's telling the same words or whatever.
Yes, sir.
Correct, no? Nothing much has changed. Okay. I have not gained much knowledge. I'm there. Maybe I'm forgetting some things.
No, sir. Thank you so much, sir. Thank you.
Thank you.
Hello.
Yes, ma'am. Shetna ma'am,
Hello.
namaskaram.
Hi. So I just wanted to ask you about TIA, suspected cases of TIA. As a neurologist, what would we, look out for? And because these are like, just query TIA, and if we do evaluate them, how do we go about it with our setup in the, neurological setup, and what do we do further? Do we prescribe? Do we send to a neurologist? How do we go about it?
So the question, I think that comes to the primary question that Pratik asked today. Whom does it belong to? It belongs to the person who cares.
Sorry, I didn't get you.
It belongs to the person who cares.
Who cares? Yeah, but then what would be our specific findings?
Most
What would be
important thing is what will you get in a TIA in a neurological evaluation? This is counterintuitive, but you get nothing.
Exactly.
Okay,
So
it is counter. This is most important, and that is the important finding. You get nothing is the most important finding. You get beautiful history. If it care to take history about 5-10 minutes, okay, you'll get nice history in these people. Very, very beautiful history. They will tell nice stories. Okay. Okay, ma'am, I want you to come to my clinic and stay with me for 5 days.
Sorry?
I want you to come to my clinic and stay with me for 5 days.
Yeah, sure. I'll come over.
Okay, to see the
Tell
kind of
me when.
histories that we take, how we talk to the patient, and all of those things.
Yeah.
Okay, some of these things are a joy to listen to for us. Okay, the kind of small nitty-gritty factors that they keep telling and all this. Okay, so we will get the thing that happens in TIA is there. What is not known is most of the TIAs of the posterior circulation are very short lasting, 2 minutes, 3 minutes. They may have a staggering gait for a small amount of time and then they settle. Okay. Okay. They will tell that I speak like a baby at that particular point of time. Okay, these are simple things. Talk to them and they will tell all the stories. Allow them to talk and they will tell the stories.
Okay.
And once that much is set on, one diplopia, one speaking like a baby, one speaking something, my tongue becomes very numb.
Heavy. Yeah.
So any one of these words they tell, you know that it is a TIA. Okay, and even monosymptomatic vertigo can be TIA up to 6 months. That much we know. If the history, all these things are important. Just start off ecosprin. The person whom you refer to, let him take the risk of stopping it if required.
Okay.
There is a certain argument in favor against ecosprin because unindicated, it can cause J bleeds. But here, once with the proper clinical history, it is actually indicated, you give it.
Okay.
Okay, ma'am. And
Thank you.
it is your problem, it is my problem, it's everybody's problem.
Dr. Srinivas sir, with your permission, I'd like to add something to whatever
Yes,
master stroke you had said. As an ENT people, we have to watch rather for press by vestibulopathy or bilateral vestibulopathy because
absolutely.
that is something which is very common. And Pratik, I'm sure he had given a very beautiful sort of a talk during our course at NMPOYA. Dr. Pushkar
Yes,
is raising the hand and I think he wants to say something. Pushkar, you can unmute yourself and talk.
Sir, I wanted to ask about patients who are having bilateral vestibulopathy, diabetic patients with peripheral neuropathy, both the things together. They are very high risk for falls, they are prone to falls. So, how to manage these kind of patients and what extra precautions apart from regular rehab exercises, what we give, what else we
sir,
have?
exercise is the number one intervention.
Apart from that, what else we have to educate to the patient and what we have to
See,
do?
as I mentioned today, drug optimization, removal of unwanted drugs, okay, this thing. But beyond all these things, the intervention which helps most is exercise. And that exercise has levels of exercise. You can take it to the level where Vijayalakshmi ma'am gives music-based therapy and music-based dance-based therapy, or Tai Chi and all of those things. Or you can simply start off as a simple quads strengthening exercise. But exercise, it is exercise, exercise, and exercise. And then if you have access to tools like that, you have a posturography system and all of those things, that will definitely help.
It
is
becomes a
like
targeted exercise.
absolutely. I will tell what is the key philosophy here. The key philosophy is better use what you have, better utilization of what you have. You have a certain amount of muscle strength, certain amount of cerebellar power, certain amount of cognitive power, all of those things. Utilize them a little better. Okay, that's it. Okay, sir.
I want to make one point. I'm
Yes,
seeing
sir.
since 3 to 4 years. So I have a kid, and for the kid, we have made some special things in the house, like so that she cannot just go and bump into other things. So I think we have to also make our homes little modified. Like those,
Absolutely.
most of the homes
Absolutely.
are having commodes. They are not having commodes. They are having Indian toilets. So if you can just tell them to use commode, install hand railings, and make that floor sangmarmar ka floor, instead of sangmarmar you keep some sheet, or you make it little more safe to walk. These things plus the rehab therapy will work very better.
Absolutely. This is like Pratik has given me some neurotology skills. I will mention all of those things. The first skill that he taught me, Yakobino maneuver. Okay. The second one that Pratik taught me was when Pratik was 3 years. Okay. The next thing that he taught the uh, arm writing test for functional unsteadiness. The third one that he taught me was take alcohol history in every patient. The fourth one today he is teaching me is that keep your house uncluttered and make it move from Indian toilet to the Western toilet. There is one place where following the West is actually good. That is in the toilet.
Yeah, one more thing, what I usually advise all these patients is they most of the, especially female patients,
Yeah.
they are reluctant to, means they wear chappals or slippers and all. I tell
Yeah.
them to start wearing shoes. That is
I
very,
will now tell something more. Sari is very, very bad choice of drug for the elderly faller.
sorry,
There
which
are
is?
sari, the Indian sari.
Sorry, okay, okay.
Sari is not a good choice for the elderly faller, and a lot of
Fully
people
agreed with you.
Yes.
they don't want
Messy.
to change. So many people don't want to change, but
They
then
don't
that is
change. They don't change.
the problem is they have to hold on one side and like this, and their normal the arm swing is gone. Okay,
Yeah.
so sari is a very poor choice. I think creating that amount of awareness. It's elegant as long as you're not falling. Okay,
Even
it's
a
beautiful,
clutter in the home,
but then
things are
absolutely, yeah,
more.
absolutely,
Kids' toys and all, everything, some
yes,
wiring,
Mm,
some stuff lying on the floor.
exactly,
Elderly people, they have difficulty. I
absolutely.
talk about this before you had joined.
Sure, sir.
And these are small things. They can be helpful.
Yes, sir.
So
I
even
think
putting anti-slip mats in the bathroom, they also
Yeah,
help.
yes, yes,
it
yeah.
is there.
Because
Anjana
We'll
madam,
take some questions. I think we'll take some questions
Anjana
because it's
madam,
yeah. Anjana ma'am, we'll
Yes,
take some
sir.
questions and then we'll
As
call it a day.
regards Dr. Hanifa's
Yeah,
query on supine hypertension,
yeah, yes, ma'am.
what the geriatricians recommend in our hospital is they tell the patient not to lie flat during the daytime, and even at the night, they tell them to keep at least 2 bricks on the head end of the bed so that the head end is elevated when they sleep, and that helps in the morning blood pressure fall.
Thank you, ma'am. Thank you, ma'am.
Vijayalakshmi madam want to talk?
Yeah. Good evening, sir. I'm Dr. Anjana.
Yes,
Yeah.
Anjana ma'am, you don't introduce yourself. All of us know you.
Sir, I just asked you this question earlier also.
Able to ask questions because you are the upcoming star of Gate and Falls, and the right to ask questions is ours.
So just
If
wanted to know anyone has experience on like using the fall risk questionnaires. We have few like time up and go,
Yeah.
TNT performance oriented and dynamic gait index and functional gait assessment. So anyone has
do you
any
have?
experience so that I can use it in our clinic. It is not that
Vijayalakshmi
cost
ma'am.
effective.
Vijayalakshmi ma'am has. You can get in
Yeah,
touch
so
with her.
that we can at least prevent the first fall itself.
Absolutely. Vijayalakshmi ma'am has the experience. I think you can talk to one another.
Okay. Ma'am is here only, ma'am.
Yes,
He's here.
he has raised hand. Vijayalakshmi madam, we cannot end the webinar without you say something.
No, ma'am, sir, before that, Sugirta is also waiting.
Yeah, she's also there in queue. Yeah.
So good evening, sir.
Good evening, ma'am.
Sir, in orthostatic hypotension, particularly in supine hypertension, any specific drugs are like, so you're telling midodrine, fluorocortisone, and droxidopa. So which of this is useful in supine
Ma'am, I have a
hypertension,
very
sir?
good neurologist by name Dr. G.R.K. Sharma.
Okay, sir.
I send it to him.
Okay, sir. So apart from this, do you have any idea regarding the carbohydrate-rich meal during the before bedtime to prevent
This is a
morning?
new idea for me, ma'am. I can check that.
So because that
That will reduce the
insulin-induced,
supine. Yeah,
yes,
that's a
sir,
good point.
insulin-induced vasodilation and all these things, and
Yeah.
so we can use a short-acting immediate release and if it depend in the night time.
Absolutely.
And, okay, sir. So
how's the weather in Karaikudi?
it's so hot, sir.
Hot now.
Yes, sir.
Okay,
So,
ma'am. The palace was wonderful. Thank you for the palace.
please visit again, sir. So we are waiting.
Definitely, ma'am.
Yes, sir.
Sugirta madam, please go ahead.
Sugirta ma'am, done, sir.
Done. Okay. Vijayalakshmi madam has not spoken yet.
Sir, I have spoken,
She
sir.
has spoken, sir.
And
Okay.
regarding Anjana ma'am's question on fall risk, we have completed a study on the association between the frailty and fall risk in
okay.
elderly, and the master chart is ready. I will be able to tell you something after 15-20 days. But for the fall risk assessment, we use the Fullerton's Advanced Balance Scale. And for frailty, we used the Groningen's Frailty Index. So I'll be able to share more data once we have it analyzed statistically.
Thank you, ma'am.
Thank you all. Okay, among all the appreciation in the chat box, there are a lot of beautiful, good points also are there. So Charu sir was talking about use of posturography and CCG is really helpful. So there are some really nice points. One more important thing before we close, progressive lenses are very bad for the elderly people. Progressive lenses, okay, they are not meant for elderly people, okay, and they have a lot of struggle when it comes to managing this thing, and it increases fall risk. So we should tell them two pairs, one black, one brown. For near work, wear brown. For far work, when you're walking around, wear the black specs. That's it. Okay, so that is one more thing that we need to tell people. No progressives in elderly. Okay, thank you.
Srinivas, these elderly people usually, the age group that we are discussing would have done their cataract surgeries, and they have the choice of lens to
They
use.
have the choice now. That's a beauty. That's a beauty of them. So there is no real
So
need.
are you saying that the cataract, you are speaking about the spectacle lenses should not be progressive? But what
should
about the
not be.
cataract lens?
Cataract lens, I'm really
Any-
not sure, but there are available. I need to give a thought to that, sir.
No, sir, no,
Yeah,
no.
so
I
it's
think,
more-
sir, if I can.
Yes, sir, Malik, sir.
Somebody who's, so the bit is two aspects which I have a little point, sir, be it the progressive lenses or be it saris. We cannot make a rule of sorts because it really depends on the adaptation. So if
Absolutely.
somebody is struggling with progressive lenses, of course, not a good idea.
Absolutely,
But people who have already adapted to them, we should have no qualms about it.
Absolutely.
And likewise, somebody who's
Same
wearing,
with
so we
sari.
have in North India.
Yeah.
Same with sari. If somebody's worn saris all their life and you ask them to change at the dusk of
But-
their...
Okay, when you see them struggling with it is what I'm telling, sir.
Yeah, exactly. When you see them struggling with it. So we can't have a... Yeah, that's also.
Yes, sir. When you see them struggling with that, of course, it should not, nothing should be a blanket rule for that matter. That's a beautiful point here.
And as regards the spectacles,
Yeah.
our ophthalmologists, especially for those with the neurodegenerative conditions and movement disorders and elderly otherwise too, they prescribe the executive glasses. They recommend that because the executive glasses provide the clear vision both when it comes to distance as well as near in one pair itself. And so they also reduce the risk of tripping and falling.
Yes, ma'am. Thank you, ma'am. So I think with that, it was a good 1 hour.
Before
1 hour and 15 minutes.
we end the session, my sincere thanks and to Dr. Srinivas Dorasala, who has given consent to be opening batsman for our DG Wednesday sessions. And I thank Pratik, who took all the efforts and has made this possible. Thank you, all the attendees.
Sir, I want to tell you something in Marathi now. I learned something Marathi today.
Oh, great. Go ahead.
मला खूप भूक आहे.
मला खूप भूक आहे. You're feeling hungry.
Yes, sir. I came all the way from.
Okay. So we'll
Just
not
today
detain you. Chalo. Thank you very much, everybody, and good
Just
night.
one announcement.
Thank you.
Before
Pratik,
Sir,
concluding remarks.
Rohiwal sir,
Pratik,
Rohiwal sir,
concluding
can I
remarks.
say something?
Yeah,
Rohiwal
please.
sir, can I say something?
Please.
Sir, thank you for choosing Srinivas Suryavanshi as the opening batsman today.
Sir, my name is not Suryavanshi, sir.
Sir, you're the Vaibhav Suryavanshi of
No,
Vertigo.
No, sir. Suryavanshi mat
Pratik,
banavo.
some remarks by you.
And Tendulkar mat banavo. Srinivas rehne do, sir.
I was...
Okay, sir.
Dr. Pratik?
Yes, sir. Yes, sir.
Yeah,
Sir, I
please
was mentioning
say something.
the next session will be on 8th of July, the second Wednesday. We will share all other details very soon in the respective groups.
Thank you.
Yes.
Thank you all. Thank you. Wonderful for joining. Okay. I love the fact that at the end of this, still 91 people are. That's great. Okay. So thank you all. Thank you so much. Rohiwal sir, beautiful host. Pratik, great work. Great job. Rohiwal sir, congratulations on starting this new intervention as
Thank you. Thank you very much. Thank you very much.
Thank you, sir. Thank you.
It's a teamwork. It's a teamwork.
Thank you all. Thank you all. Thank you.
Thank you so much.